My name is Amber Ham. I'm the Training and Outreach Coordinator with Kentucky Spin, and we are so excited to have you today as we learn about understanding early periodic screening and treatment, or EPSDT. I'm going to go through a few housekeeping items before we pass things over to our guest speakers this morning. A little bit about Kentucky Spin, or Kentucky Special Parent Involvement Network. We are the Parent Training and Information Center, or also known as a PTI, for the state of Kentucky, funded by the U.S. Department of Education under the Individuals with Disabilities Education Act since 1988, when Kentucky first received a PTI. Kentucky Spin Parent Center provides training, information, and support for children and youth with all types of disabilities, birth through 26 years old and beyond, as well as their parents, family members, and professionals that walk alongside of them through their journeys. At Kentucky Spin, it's important that we let everyone know we do not act as attorneys. We do not legally represent families. We're not representatives to families. With that being said, we empower families to advocate for themselves and their children effectively by providing a peer-to-peer model of support that then helps families access needed information and resources. A brief disclosure about today's training is that this is not a training of trainers, or also known as TOT event. Kentucky Spin does not authorize other agencies, organizations, or individuals to train the material. Third-party recording or streaming is strictly prohibited, and the presentation is for educational use only. All rights for use are reserved by Kentucky Spin Incorporated. We also most of us are working from home. We do ask for a little grace during this presentation. You may hear a noise in the background or maybe some brief delays in internet. We do apologize in advance for those things, but we have some wonderful staff on here that can pick up and assist at any time. Please utilize the chat function or the Q&A function if you do have questions throughout the training today, and we'll get to those just as soon as we can. We will also be placing links in the chat throughout the presentation, and you will have access to those. If you're unable to grab those, no fear. We will get those to you in a follow-up email that will come out about 24 hours following the very end of this webinar. And at this time, I am going to pass things over to our guest speaker, Justin, and I will let him introduce himself as well as some of his team members.
Good afternoon. While I'm getting this set up here, I'm Justin Shaw. I'm the branch manager of the Maternal and Child Health branch within DMS. I'm really excited to be here with you today to talk about EPSDT and school-based services. I have a couple others with me as well from my branch, so I will let them go ahead and introduce themselves while I'm getting the screen shared. I guess, Shantae, if you want to start.
There we go. Hi, I'm Shantae Jordan. I've been with DMS for about 2 years now. I am an EPSDT specialist, and I really appreciate you guys reaching out to us and wanting us to be here. We really do want to get the word out about this benefit of Medicaid. So thank you guys very much, and I hope you guys take something from it.
Okay. Annette, do you want to? You can hear me. There you go.
Hi, I'm Annette Newsom, and I deal with school-based services. So if you, I've been with Medicaid now about a year and a half. So if you have any questions, please feel free to let me know or email me at any time.
And then Ivy.
Hello, I'm Ivy Sams. I am the EPSDT coordinator. In this part of EPSDT, we deal with the treatment part, all of which requires prior authorization. And there'll be a link in the coming screens if you need to contact me. There is a email for EPSDT in case you need to ask questions about the treatment that you might have need of for your clients.
Thank you. Let me try this again. Sorry, everyone. Well, this is what I get for which screen is it sharing?
I
That's one
just
with-
feel so much better that it's not just me.
I
I just, is everybody in the same boat?
I am so sorry.
You are all good. We
Okay.
appreciate y'all so much.
Absolutely. And that looks perfect,
it.
Justin.
Right, you can't see my notes anymore. This is
Nope.
what I was- Perfect. Thank you. I am again so sorry about that. Well, with that gone, let us go ahead and get started with the presentation for you all. Again, thank you for being here. I'm going to talk about EPSDT and school-based services for you all. We do have some items that we'll need to go over at the beginning, just some kind of brief information about Medicaid, that sort of thing. But reposition everything. Sure, as you all know, Medicaid, it's the largest medical assistance program for low-income individuals in the country. Began in 1965 under Title 19 of the Social Security Act. It's a program where both the federal and state governments pay into it. We both provide funding for it. Federal government tends to pay a little bit higher percentage to the states for the program. Federal government has some very broad rules for the program, requirements, things we have to do. But the states, we do have some flexibility in how we administer the Medicaid program, which we're going to talk about a little bit with when we talk about expanded school-based services later. So, as I said, it's funded both from federal and state funds. That's called the Federal Medical Assistance Percentage, the FMAP, is how much the federal government is going to reimburse, is going to pay to the state to help pay for the program. It's determined by a state's per capita income. And this slide here, it just kind of shows some brief information of how much we are receiving in federal assistance for the different programs and types of Medicaid that we administer here in Kentucky. As you can see here, Kentucky is one of the largest. We have one of the higher FMAPs in the country. So that's really all this one here is showing you. Some things you may not have known about Medicaid. It's 1.4 million Kentuckians approximately in the state are enrolled in Medicaid. That's almost 31% of the entire population of Kentucky is enrolled in Medicaid, with more than half of Kentucky's children receiving Medicaid. So Medicaid is responsible. It helps that a third of the state receive the medical care that they need, keep them healthy. So, and what that means in pure dollars is we spent $18.5 billion in state fiscal year 2024 for benefits and administration of the program. It's a huge chunk of the state's budget every cycle. You're in DMS, we have 7 divisions led by Commissioner Lisa Lee. Our division that I'm in is the Maternal and Child Health Branch, part of the Division of Healthcare Policy. And what we do is we are responsible for developing regulations, how federal law applies in different ways. We create policies and procedures for the programs in maternal and child health care, physical health, and pharmacy. So this is just the 7 divisions that we have. We all do something different. Sure, as most of you are aware, MCOs, managed care organizations, actually administer the program for most enrolled members. So they are responsible for basically managing the care that individuals have, kind of like health insurance. Private health insurance, they kind of cover those sort of things. They must cover all services that are in the Medicaid regulations and our state plan, which is just kind of what we say we're going to cover, what they're required to do, things like that. One of the nice things about MCOs is that some of them do provide additional benefits. So you can get things like gift cards, you can get transportation. Some of them offer like technical equipment for schools, things like that, for doing things that you're doing anyway or taking your child to do, going to the doctor, completing screenings, a whole host of things called value-added benefits. So it's definitely something you should check out. Might as well get some extra benefit out of taking your kid to the doctor, you going to the doctor, things like that. And then for those who are not part of an MCO is our fee-for-service population. And as you can see, that's going to be the ones that are receiving waiver cares, long-term care, things like that. Those programs are directly administered by DMS, and it's, like I said, mainly for individuals with disabilities or the elderly. And then this last one, before we move on into the topic of the presentation here, is just kind of the top 20 expenditures that we have by Medicaid in the state in fiscal year 2024. They can see a lot for hospital and pharmacy, things like that. But moving into the actual topic of the presentation, early and periodic screening, diagnostic, and treatment services. What is that, right? It's Medicaid's comprehensive and preventative child health program for individuals under the age of 21. It's also in the Social Security Act. If you're ever curious and want to get into what does the law actually say about the program, it's in Section 1905R of the Social Security Act. Very legalese, it's a law. I find it interesting to read sometimes. What the great thing about EPSDT is that it guarantees healthcare resources are available and accessible to help Medicaid recipients and their caregivers use them. So it's there to provide early and periodic, to provide help, find some issues early on, fix them, resolve them, and do what we can there. So, as it suggests, services provided must be focused on the early detection of disease or abnormality, any kind of health risk, health disease, health issue, things like that. It helps provide for immunizations that are age appropriate. And should referral services be necessary, and they meet all the EPSDT special services, even if they're not covered by Medicaid normally, they must be covered by EPSDT benefits. So I'm going to talk about that a little bit later on in a few slides, what that means, what you need to do for those services that aren't normally covered by Medicaid but are by EPSDT. So again, what does it all mean? And we're going to talk about each word in EPSDT means something specific. So early, we want to assess and identify, detect these problems as early as we can, because that leads to the best outcomes. We do that through a number of ways. We do it through periodic health checkups for individuals. It's really going to be the best way to detect problems early on is if you're getting those periodic checkups. You're going to the doctor every year. If it's a newborn, you're going every first month and 3 months and 6 months to make sure that everything's normal. There's no issues going on. So it's really what the periodic is. We want to have this early detection through this periodic checkups with individuals. And even outside of the regular periodic kind of periodicity recommendations for individuals to receive checkups, immunizations, that sort of things, children can receive those additional checkups when a condition or problem is suspected. So if something's found, we need to do some more look into it. It's going to be covered by the EPSDT benefits. Screening. So screening is exactly what it sounds like. It's screening your children for any potential health risks. So it's done through a number of ways. So it's providing that physical, mental, developmental, dental, hearing, vision, and other screening tests to detect potential problems. As I said a couple times now, all children and infants and adolescents, they should be receiving those regular well-child checkups. And those checkups should include, and actually must include for the EPSDT screenings, comprehensive health and developmental history. So they have to have a physical and mental health development assessments. There needs to be a physical exam of the child. As I said, age-appropriate immunizations for them, vision and hearing tests, dental exams, and any laboratory tests that they may need, blood level, blood lead, anything like that. And then some health education for the child and parents, how to stay healthy, what they need to do if there's anything going on. So that's how that's how they're finding some of these issues. Diagnostic. The health issue or risk is found, diagnostic test should be performed. And said anything that is found that's medically necessary, it's going to be covered by the EPSDT benefits, and that's going to be done through the treatment portion of it. So once a health problem has been identified, we want to assure those children that they're receiving the necessary treatment to control, correct, or reduce their health issues. So we want to find it, we want to fix it, we want to make sure everything's good to go for them. As I've said, EPSDT, we must provide and pay for treatments considered medically necessary. And we're going to talk about what that means in a few slides. What is medically necessary? How do we define it? How do we determine that? That includes any services, vision, dental, hearing, other health-related. Interestingly, while, as I said earlier, federal government has some very broad kind of requirements that we have to do in a state. Medically necessary, the definition isn't one of them. That's defined on a state-by-state level. So like I said, we're going to talk about how Kentucky defines it in a few slides. This slide here is just the periodicity schedule. So it is just a chart that lists kind of the ages and the different types of checks that should be happening at those ages. I'm not going to talk a ton about this, but we wanted to provide it to you all to make sure you have the most up-to-date version of this. This does change periodically as new health information and guidance comes out from various health organizations, but this is what we're currently working off of here. So if you want to take a look at that and see what's going on, what you need to be doing, what you should be doing, what your child should get, have at it. And this one, the origin of EPSDT. This is something that when I came to this branch and began working on this in January, I didn't know this. I found it very interesting on why EPSDT was created. And the reason for it was that in 1962, half of all men drafted into the military were rejected. Typically, it's about half for medical reasons, the other for failing mental tests. And it found that, so a task force was created by President Kennedy. It found that a third of young men turning 18 would be ineligible for military service. During that time, that was a huge problem for the country with some of the things that were going on. So this task force, they tried to figure out what can we do to fix this? How can we fix this? How can we make sure our children are healthy? We have people available for military service. So what they did is they came up with the idea of early EPSDT, creating a nationwide program to ensure health, education, and training of youth to become effective and self-supporting citizens. And then in 1967, that legislation was enacted, authorization was provided, and funding was given for the EPSDT program. That's just something I found very interesting. So I like to include it when we talk about EPSDT. So there it is. Now, as we said, that any medical service covered through Medicaid normally is going to be available for EPSDT. This next couple slides are just some examples of services that are already covered under EPSDT without any additional action or prior authorization needed. It's not an exhaustive list by any means. It's kind of some of the common ones that we have. Physician and clinic services, private duty nursing, physical therapy, speech therapy, bunch of different things that children may need take care of their health. So if you want to look through this, kind of look and see what's there, great. Now, something that people may not know, or maybe something that may not be seen as important for children because they're going to lose their teeth, that sort of thing. But dental services are also covered under EPSDT. So among the services provided, does preventative services, so cleaning, sealants, fluoride treatments, does those x-rays, it'll do that oral health screening, see if a child is at risk of tooth decay, want to take care of that and make sure it's not there. And then it provides some treatments as well, some crowns, cats, fillings, root canals, Team J treatment, and some orthodontics are covered as well for children under the dental EPSDT service. Again, this is not exhaustive list of what dental services are covered, kind of some of the major ones that are and children should be receiving as needed there. Totally covered by EPSDT Medicaid. That's kind of high level EPSDT information. So we're kind of going to switch gears, or excuse me, sorry, kind of out of order there. You said Medicaid, EPSDT has to cover all Medicaid services that are already covered. What about those services that an individual needs, that treatment that a child needs, that may not normally be covered by Medicaid and needs a prior authorization? So that's what we're going to talk about here, the special services treatment under EPSDT. And all prior authorization means, for those of you who may not know, is it's basically just that the provider has to submit documentation and information to DMS or the child's MCO prior to the service being approved. They're going to look at that. They're going to see if it's medically necessary, if it's required. Why is it being done? Why do they need it? That before they can approve it. But if it meets that requirement, that medically necessary requirement, it's going to be covered under EPSDT. So kind of what I just talked about for you all. I just forgot to change the slide, sorry. There. So I'm not going to rehash it for you. This slide, again, it's some more information about what I just said. Section 1905, subsection A4B in the Social Security Act kind of talks about the other necessary healthcare and diagnostic services. Again, just a little bit more information if you're ever curious about what the actual law says about it. But what is medically necessary? What is medical necessity? As I said earlier, it is something that's left up to the states to define. So in Kentucky, these are the guidelines that we use to help determine if something is medically necessary or not, a treatment that may not otherwise be covered by Medicaid. I am going to read this slide to you all because this is how we do it. So first up, it's a reasonable, so the treatment has to be reasonable, appropriate, and effective method for meeting the client's medical needs. The expected use of that treatment must be in accordance with current medical standards or practices. It just basically means that there's clinical guidelines for it. They exist. Treatment providers, doctors, they have some guidelines they're going to follow while they're giving this treatment. it's cost effective, and it provides for a safe environment or situation for the client. We don't want them to do something overly risky for their health. We want to make sure that it's effective. It's something that is normal, and it's going to solve. It's going to help the child. It's going to help ameliorate or resolve the issue that they're having. Now, this is how we define medical necessity. But if the treatment has any of these elements in it, it is not going to be considered medically necessary. And as we're going to see here, it can't be experimental or investigational. So like we said, it has to be, back a slide, has to provide a safe environment, has to be effective, there has to be clinical guidelines. If something's experimental or investigational, there's not going to be those guidelines. We don't know how safe it is for the child to do, things like that. So anything experimental or investigational is not going to be considered medically necessary. It can't simply be done to enhance the personal comfort of the client. It can't be elective, essentially. It can't be done simply to provide convenience for the client or the client's caretaker. These next two bullets kind of feed into number one, where it's experimental. It can't take the place of clinical guidelines or evidence-based medicine. Again, just can't be that experimental. We have to have some guidelines. We have to know it works, essentially. And a single provider can't write an order and override the lack of evidence-based medicine. So it's never been done before. A single provider can't just say, this is absolutely going to help. We need to do it. That's not going to work when we determine if something's medically necessary or not. And one of the things that we've seen recently come up as something that's not normally covered by Medicaid but is by EPSDT is that ABA treatment for individuals, if it's considered medically necessary by the provider, that is something that's going to be covered by EPSDT benefits. Just as an example of something that's not normally but is under EPSDT. So what do you do if you need to have one of those services that is not normally covered but needs to be prior authorized? It's pretty simple. You talk to your provider or your physician, the treatment provider, about it, figure out what's going on, if they think it's medically necessary. Your provider should understand the process, what they need to do to submit that prior authorization. But if they ever do have questions, and as Ivy mentioned earlier, there is a link on this slide. I know you all can't click it from here, but if you want to type that in and go to it, it's just kind of some more information on the prior authorization process for individuals, what forms need to be completed by the provider, things like that. You can always go there. Or if you or the provider has questions about anything, reach out to our inbox, dms.epsdt@ky.gov. Happy to answer any questions that you send there, get you some more information, figure out what's going on to get the treatments that are needed for your children. Okay. Now that we've talked about EPSDT, what's covered, what's not covered, what you need to do if something's not normally covered, what it is, we're going to talk a bit about school-based services, school-based health services, kind of work together with EPSDT and providing some EPSDT benefits, that sort of thing. But what it is it's a program introduced in the late 1980s where it allows your local education agencies, your school districts, your schools, to enroll as a Medicaid health provider to allow school districts to receive some reimbursement for the health services that they are providing to their students. So Medicaid will help pay for some of the services they're providing, the medically necessary educational attainability services that are being provided in schools. So I'm sure many of you, if you have a child with an IEP, you understand, you have an idea of what school-based services are. Because it was a program that was only available for individuals with IEPs for a very long time. And only those specific services that were mentioned in the IP were able to be reimbursed and provided. However, in November of 2019, Kentucky, we were allowed to expand school-based services to more than just students with IEPs. Something called expanded access school-based services. And it works similar, such a difficult word to say, similarly to school-based services, except it's for all children in the school. So when it does, it allows local education agencies to bill Medicaid for eligible services provided to a Medicaid member without requiring an IEP first. Not every school district not every local education agency has enacted expanded school-based services yet. We are working on that. We're going to see some numbers later in the slide of where we are. So what we're trying to do is get that expanded for individuals, because we want to have that access and that care available to anyone who may need it in the school. So the goals behind this expanded access is that, and it's increasing student access to health services. It's really been a boon to helping increase some of that student access to services. It can allow parents, you don't have to miss work. You don't have to pull your child out of school to take them to an appointment. They're going to miss half a day of education, of learning, because you're driving them back and forth, waiting in doctor's offices to see someone, to get some health services. So if those schools can provide it for the child at school, it's a place they're comfortable, they're out for however long the appointment is, and they're right back in class. So we're really focusing and trying to get that expanded to increase that student access. It also helps reduce the administrative burden on schools, this expanded access, because it increases their access to funds to help pay for services they may already be providing to students in their school. Extra funding goes a long way in schools. Everyone knows how more funding is needed in many areas for that. Qualify for a student to receive an expanded school-based service, to receive that health service in school, and for it to be reimbursed by Medicaid. A portion of it to be reimbursed by Medicaid is one, must be medically necessary. Gone over that, so we want to make sure that it's required, the student needs it, and it's going to help them. It has to be a covered service. So it has to be a service normally covered by Medicaid. It must be provided by a credentialed practitioner. Can't just be some Joe off the street. Has to be a doctor, has to be a nurse practitioner, someone actually licensed and credentialed to provide the service. Must be provided to a Medicaid member. So schools can only be reimbursed, can only bill Medicaid for someone who is enrolled in Medicaid. And it also must be a service that is offered to all students at no cost to the student or the family. So schools and those local education agencies won't be able to get reimbursement for everyone they provide the service to, but any Medicaid members they can. So it's still helping to get extra funding and provide that service in schools for individuals. So another requirement for local education agencies before they're able to bill Medicaid for their Medicaid members is they must have parental consent. So that's just you saying, yep, I consent, signing a form, I consent, you can bill Medicaid for these services for my child. You're not required to consent to the school billing Medicaid. It's not a requirement. It's your right if you want to allow them to do that or not. If you don't, they can't bill. If you don't initially provide consent, you can always come back later and say, oh, you know what, I do want to have these services. I do want you to be able to bill and get that funding for it. And vice versa. If you provide consent initially, you can always revoke it at any time. You only have to consent once. So a lot of times you'll see it when you're beginning of a school year, if it's a new student in a school, big old packet that you get with information about the school, what's going on. It'll have that parental consent form in there. Once you sign that for the first time, It's great. School will have it. They'll keep it on file. You don't have to sign another one every year. They do have to tell you, give you kind of information on it every year, just letting you know that it's still ongoing, that sort of thing. As I said, you can always revoke consent at any time. The only caveats to only having to sign at once is there are 4 reasons you may have to sign another parental consent form. That's if the child's custody arrangement changes. So if you're divorced and child goes from one home to the other, one parent to the other, you're both going to have a consent form because it's a different custody arrangement. If child moves foster homes, consent must be obtained for each household. Kind of goes into the custody arrangement reason. If the child leaves the district for any amount of time, you'll have to sign a new one when he or she comes back to the district. And as I said, should the child's arrangements not change, you'll get an annual notification about the consent. That's all that's required. You don't have to sign a new one. The most important thing to remember about parental consent in allowing the school to bill Medicaid for those services they're providing is that it does not affect your child's ability to receive Medicaid covered services outside of the school setting. Only allows the school to bill Medicaid for those services provided to your child at the school. So it's not going to take away your parental rights. It's not outside of the school. It's not going to take away, like I said, their treatment outside schools, things like that. So please remember that when it comes to it's a very important part of the parental consent. And then, so I know, okay. So within kind of the expanded services is a new initiative called Shine Kentucky. And that's a program that we began in July of last year. We were, along with 17 other states, provided with some funding from the Centers for Medicare and Medicaid Services, CMS, to assist in implementation, enhancement, and expansion of the use of school-based health services. Kentucky, we received $2.5 million of that $50 million that was given to the 18 states for enhancing those health services, including, and this is really our first big initiative with the program, access to and provision of, behavioral health services, mental health services is kind of what we're focusing on, which we'll talk about in a second as well. SHINE, it stands for Strengthening Health Integration in Education for Kentucky. It's a collaborative effort between a bunch of different departments and groups. So you've got Department for Medicaid Services, which is us. The Lieutenant Governor's Office is really involved in this program. Department for Behavioral Health, Developmental and Intellectual Disabilities, BHDID, if you ever see those acronyms, your Division of Family Resource Centers, and the Department of Education, all working together on this program to again, enhance and improve and increase the use of these school-based services for children. It's a 3-year project, started in July of last year to run through the end of June of 2027. So we're just kind of in the beginning stages of it. I'm really excited about this program. And like I said, one of our first big initiatives has been an emphasis on mental health of children, particularly how those mental health services can be provided in a school setting. So just some information here from the National Alliance on Mental Illness, NAMI. And this was surprising to me when I saw it. 1 out of 6 U.S. youth aged 6 to 17 experience a mental health disorder each year. Half of all of those mental health conditions begin by the age of 14. Kids are in school half the day. They're probably in school while they're awake more than any other place in their lives. So they're spending all of this time in these educational settings. Schools, they offer this unique kind of opportunity for the early identification of any mental health issues that may be there, prevention and interventions They're seeing these teachers all day, principals, their friends, things like that. It's a really big place to kind of identify early and get treatment and help where it's needed. And in 2019, 15% of adolescents aged 12 to 17 reported receiving mental health services at school. Ideally, that number would be 0 because we wouldn't have any mental health issues, right? But we would like to see that number much higher for those who actually do have these issues that need worked. We'd like to have a higher, more than 15% of that age group receiving that care in school if they can, because it is such a unique setting and it is so helpful to get it in a place they're comfortable. So here and this is one of the ad campaigns that we have created around this idea about the mental health initiative, and it's actually in place in Louisville. So any of you that are in Louisville, I think most of you may be, you may have seen some of these out and about it. So in March of last year, we began this campaign to increase the awareness of mental health services offered in Jefferson County public schools. Our goal is to increase the number of school districts in the state who are able to provide these types of services. We thought Jefferson was probably the best to start with because of how big Jefferson is as a county and the number of students there, and just kind of the providers that are available in the area. But we really want to roll this out as we are throughout the state, so that all kids in Kentucky have the availability and the ability to receive these services. So these next few slides are really just kind of some ideas or excuse me, images of the campaigns that are out there. So just wanted to kind of show these all to you. Said the goal is to raise awareness. So these numbers are a little bit outdated. We do have newer ones. I just wasn't able to get them added. More recent numbers. This is from January of this year. 377,000 consumers digitally have seen these ads with 9.4 million impressions. So they popped up on your screen 9.4 million times. People have seen it. 53% of our audio impressions and 27% of Facebook impressions have been delivered to Spanish parents. So trying to make sure that our Spanish speaking population are aware of these benefits of this program and these services as well. So the numbers are much higher now on these, but they're very good numbers, hoping to up the number of students receiving these services in the schools. Now these next few slides, and this may be information, it's probably information a lot of you already know. So I'm not gonna spend a ton of time on them, but it's about Medicaid eligibility. How are kids, what's the eligibility requirements? How are they eligible? Things like that. So Magi Medicaid and K-CHIP. K-CHIP is just the Kentucky Children's Health Insurance Program. It's a free health insurance program for families without health insurance and with an annual household gross income at or less than 218% of the federal poverty level. That's for children under the age of 19, so up until they turn 19, currently pregnant women, and women within 1 year of their postpartum period. Financial eligibility, it's only income. We don't look at resources in Magi eligibility. It's determined using, it's fairly simple. It's much simpler than the other type of Medicaid we're going to talk about in a second, is the Magi methodology. We take the household's taxable income, the household's taxable income, minus specific deductions. So things on like the Schedule 1, when you file your taxes, are considered deductions for Magi eligibility income. We compare that monthly amount to the federal poverty level for your determination group size, which is basically just who's in your tax household generally. And if it's below that level, child's eligible for one of these 3 groups. You're eligible for K-CHIP or Medicaid, depending on your income. Also must meet citizenship or qualified immigrant requirements. Children legally present in the country are qualified immigrants. They're eligible. They meet that requirement. They don't have to be here for a specific period of time. And as I said, resources aren't considered. So we don't look at your checking, savings, life insurances, anything like that. Simple. It's the majority, the vast majority of Medicaid recipients that are children in the state are MAGI or K-CHIP. And then this is just a chart of the K-CHIP income limits. So as you can see here, it has your household size, it has the percentages, federal poverty level percentages for you. And this is a monthly income kind of chart is what K-CHIP and MAGI look at. So this is for April 2025 ongoing, changes annually when the FPLs are updated. So you can keep this will be good until the FPLs change next year, typically March or April is when those are updated. Now non-MAGI Medicaid. This is the more complicated one, and one that as a household, you can actually potentially have income higher than the MAGI income standard at 218%, and your child still be eligible for non-MAGI Medicaid. So we're going to talk a little bit about it, provide a little example because it is a little bit more complicated for that. And I want to make sure everyone understands that this is potentially available for children not otherwise eligible for MAGI Medicaid or K-CHIP. So non-MAGI, it's Medicaid for age-blind and disabled individuals. Have to meet certain technical requirements, same as MAGI requirements. Provider apply for an SSN, be a Kentucky resident, cooperate with third-party liability. So if you have other insurance, you got to agree to bill that before you bill Medicaid, things like that. For a disabled child, they have to be determined blind or disabled by either the Social Security Administration or the medical review team. It's the same determination. They use the same criteria between the two, but medical review team is something that like the DCBS office can do for a child. And you got to be a U.S. citizen or a qualified immigrant. Like MAGI, if it's a child legally present, lawfully present in the country, then they're considered a qualified immigrant for this requirement. Now you're going to look at this next part, and you're going to wonder if the countable income has to be $235 or less a month. How can a household have more income, monthly income, than MAGI and still be eligible? And I'm going to talk about that in the next slide. I think the next slide. It's a very low number, but there's a lot of deductions that go into it. The other main difference from non-MAGI is we do count resources, and that's for parents and the child. And you have to have countable resources less than $2,000. For one parent home, $3,000 for a two-parent home. And just listed some of the common countable resources that are considered there. Like I said, how can it happen? How can you have this income higher and still be eligible at that $235? So we take all countable income belonging to the parents and the child, count it all up, add it all together, take it from there. We allow these 4 deductions from that total income. $20 general exclusion. We subtract $65 from earned income and have the remainder. There's a parental deduction. That's a standard deduction that we give, and then an ineligible sibling deduction as well. I'm not going to read all these numbers for you, but these are the 2025 deduction numbers, allocations is what they're called, that we provide from the income, from monthly income. And now the example. So we have Mary and John. They have 2 kids. Of course, he's disabled. He's on a waiver waiting list, so he's not eligible for Medicaid, long-term care, Medicaid. So we're not just going to solely base our eligibility on his income and resources. They're not eligible for MAGI or K-CHIP because he has income. John's income is $7,400 a month. That is $88,000 a year. It's about $18,000 higher than the MAGI eligibility standard. But when we do all of the allocations and deductions, we can see that that $7,400 that John makes every month is actually only $189, considered $189 of countable income for Chris when we determine his income eligibility. So he would be income eligible for Medicaid as a disabled child. It's tough to meet the resource eligibility requirement. That's a little tougher sometimes for parents with resources, but income-wise, potentially eligible. So if you think, if your child doesn't receive Medicaid, you think you make too much money, you may not. You might want to plug in some numbers, talk to DCBS. They can make that determination for you. Can't hurt to try. So we want to make sure that you have that availability. And then how do you all apply? I'm sure you all know this, but you can go online and do it yourself. Sometimes never have to talk to anybody at all. You can do it all online, upload what you need. It's great. You can go to your local DCBS office, the DCBS contact center, excuse me, or there are paper applications that can be completed and turned in. Who can apply here? Your parents are going to be applying for your children, but you can have an authorized rep. You can have if child has a power of attorney, anything like that can apply for a child. And then last, before we get into some billing stuff, so it may not be as important for parents that are listening, providers may be interested in, is the Dolly Parton Imagination Library. Don't know how many of you are aware of this program. It's a fantastic program where Dolly Parton, she will send free books to children from 0 to 5 years of age, from birth to 5 years of age, every month, no matter your income level, no matter where you live, anything like that. The only requirement is to be a child from 0 to 5. It's great. I know when I moved into my house, the old resident received it for their child. Didn't get forwarded to them for some reason, and I wasn't able to get into contact with them, but I gave it to some friends of mine with young kids. They immediately signed up for the program after to get those books for them. I would definitely check it out if you haven't seen it. We're really trying to push some awareness on this. It's just imaginationlibrary.com is where you can go. You can sign up, get some more information there. I'm telling you, a fantastic program. Check it out for you. And now we're going to move on to these last few minutes, try to knock it out in the next 7 minutes for you all. Only a few more slides left. Are the how do schools bill for these school-based services? What are we doing? What's going on with that? How do you get involved? So there are 3 programs within the school-based services billing portion. Billing agent, you got the school-based administrative claiming, so they claiming their administrative time, and then the cost reporting, cost settlement. As I said earlier, before any of this can be done, before they can bill Medicaid for any of this stuff, they have to have that parental consent from you all signed and on record. Can't bill legally if they don't have it. What are those 3 groups? So a billing agent, just an entity that offers claim submission services to providers. They have an agreement with the provider to submit Medicaid claims on behalf of the provider. The provider in this instance would be the local education agency filing those claims with us. They either enter their claims into the system after verified release to Gainwell, which kind of reviews them all. There are 3 billing agents in Kentucky: Info Handler, Public Consulting Group, and Civic Solution Group. So the school is working on it. If you're in a school district, if you are a provider, you want to work with the school, maybe want to reach out and talk about some of this with them, providing services to them. School-based administrative claiming. It's a program that offers reimbursement for the cost of administrative activities, such as outreach that support the Medicaid program. So kind of as an example, here you have KDE, Kentucky Department of Education. They contract with PCG. PCG uses their data to do random moments time studies. So they collect data on what exactly a provider was doing at the moment that they were polled. And then they send some independent school data to DMS. The DMS kind of reviews all that to figure out what was going on, what they're being paid for, what they were working on during that time. to participate in this, to participate in this school-based administrative claiming, they also must participate in the cost settlement program. And all that is it compares the fee-for-service payments received throughout the year to the actual cost collected on the cost report. So just reconciling how much did you bill, how much are you eligible to receive in reimbursement, and then it matches. So if they bill too low, if school billed lower than they're eligible to receive, they're going to receive up to what they later in the year, when this is done, receive some extra. If they were overpaid, then the school has to repay. We would prefer you receive extra and not have to pay anything back, but those are kind of a couple of things that happen with the cost reporting settlement. So going over again some of the requirements for billing. Only bill for children with Medicaid. Medicaid's only going to pay for Medicaid eligible children. They must have a current evaluation of the child. They must have a reimbursable service listed in their IEP, and or the service must be medically necessary for that expanded access service that's being provided. The provider can't be paid 100% with federal funds. There has to be some state funding or local funding in there. If it's 100% federally funded position, they're not going to be eligible for this reimbursement. If they are split funded, so some state, some federal, some local, state and federal, we're only going to reimburse, they can only claim for the non-federal portion. And then, as we keep saying, parental consent, must have parental consent from you for the school to bill. A couple different billing models that schools do. Some schools hire staff and bill for their services, so they hire their staff directly and handle it. Some schools contract with providers, and those providers bill for their own services, or some schools contract with providers, and then the school bills for those services. So it's contracts basically where they're hiring the staff directly. And then these last two slides are just some quick kind of growth of expanded access that's being provided. So as you can see on the chart, every year since expanded access was begun, we've gone up. We've increased the number of schools that have, or local education agencies that have bought into and implemented the program. The ones that have billed is still lower than the ones that have signed up. We're trying to work on that and figure out what's going on and increase those that are utilizing it. If you signed up, might as well use it. And then just the same information, just in text form for you all. So as you can see, we have 171 school districts in the state, 163 provide school-based services. That's the ones for the IEP individuals. We've gone from 50 expanded access schools in fiscal year 21 to 62 this year, fiscal year 25. So big growth that we've seen. That's 37% growth in the number of schools that are participating, something like that. Hoping to get even more, hoping to get up to all 171 at some point in the future. But yeah, that is that. And that is actually the very last slide, coming in right at 1 o'clock for you all. Again, thank you all for being here. If you have any questions about anything, as I said earlier, Annette Newsom, she is the school-based service coordinator, so you can always email her at Annette Newsom at net.newsom@ky.gov. You can email me, justin.shaw@ky.gov, or Erica Jones, our assistant director, erica.jones@ky.gov. Or if you have an EPSDT question, that dms.epsdt@ky.gov email address is available for you all to reach out and ask your questions and do what you need. So just thank you all for letting me speak and listening to me for an hour. I appreciate it. And I will turn it back over to Amber.
Thank you so much, Justin. And that was a wonderful, wonderful presentation. I learned so much myself, and I really enjoyed even hearing back to the history of why EPSDT is there and what the purpose was. So wonderful information. We do want to thank each and every one of you for joining us today on your lunch break.